This is the third session for the Virtual Research Academy under the Saudi Heart Association, Saturday, 22nd of January, 2022. It's my great pleasure to have Dr. Wael Al-Garaawi with us today. And over this hour, he will talk to us about basic statistics, survival tips. Dr. Wael Al-Garaawi is a cardiologist and electrophysiologist with a master's in clinical epidemiology, assistant professor at King Saud University, and adjunct professor at the University of Ottawa, Canada. Dr. Wael will guide us through some basic statistics. And whenever we read articles, we get some challenges understanding them. So today he will talk to us in the next 30 or 40 minutes or so about these issues. Without further ado, the mic is yours, Wael. And please, for the audience, if you have any questions, please feel free to pose your questions in the Q&A. Mic is yours, Wael.
All right, thank you very much, Prof. It's truly my pleasure to be with you today, and congratulations on this great initiative. So today we're going to talk about statistics, which can be a dry topic. So I thought what we could do is simply answer 10 basic questions divided into two themes. One is statistical significance, and the other one is adjusted analysis. And I think that most of what we need is really about statistical significance and adjusted analysis. So moving to the first question, why do we need to test for statistical significance? And to answer this question, we're going to consider this real life scenario. Let's say you're having a surgery and there are two surgeons in town. So for you to decide which one to go with, you wanted to look at their complication rates to see if one has a higher complication rate than the other. So you look at last year and you find that surgeon A did 40 procedures and had 2 complications. So that would be a complication rate of 5%. Surgeon B did 70 procedures and had 2 complications. So that would be 2.9%. So question to you now, would you feel confident saying that surgeon A has a higher complication rate than surgeon B? I think all of us, or at least most of us, would say no, right? These are small numbers. The difference is small. Maybe surgeon A had a bad year. Maybe by chance had 1 or 2 more complications. So, you know, all of us would say this is not enough. We wouldn't feel confident saying that surgeon A has a higher complication rate than surgeon B. So you then look at the last 5 years and you find that surgeon A did 250 procedures, had 13 complications. So that would be 5.2%. Surgeon B had a complication rate of 2.6%. Now back to the same question. Would you feel confident saying that surgeon A has a higher complication rate than surgeon B? Too bad we can't see votes, but you know, I think some of us might say, yeah, maybe. Most of us would say, I'm still not confident. So you weren't confident. So you looked at the last 20 years. And what you find is that surgeon A did 1,000 procedures, had 55 complications. So that would be 5.5% complication rate. Surgeon B did 1,200 procedures and had 36 complications. So that would be 3%. Now back to the question, would you feel confident saying that surgeon A has a higher complication rate than surgeon B? I think most of us would say yes. And this is exactly why we test for statistical significance. This is essentially plain English explanation of statistical significance. And actually, if you calculate the p-values, and these are real p-values, they correlate with this confidence about the difference. So in simple terms, we test for statistical significance because we want some confidence that our findings are not due to chance. Note that I say some confidence. So it's not proof, that's one thing. The other thing, it's not white or black. You don't move from yes, this is not due to chance this is due to chance. Although we use the conventional p-value of 0.05, the better way of thinking about this is that it's a piece of evidence. And you see how we moved from we're really not confident to, yeah, maybe we're a bit confident to, yes, we're confident that this difference is real. And if you think about statistical significance that way, you know, your interpretation of the literature will be much better. All right, so next question. What are the determinants of statistical significance? Meaning, why do we sometimes find statistical significance and sometimes not? And there are two major determinants. First one is the sample size. This is a graph showing the effective sample size on the p-value for the same intervention. And where you can see here that the higher the sample size, the lower the p-value for the same intervention. We're talking about the same intervention. The second, and if you actually think about that, if you go back to the example we talked about, all what I did is actually just increase the sample size. If you look at the complication rates, they're very similar, you know, 5, 5.2, 5.5, 2.9, 2.6, 3. So the events, if you like, are essentially the same. The difference is essentially the same. But to convince you, for you to have more confidence, i.e. statistical significance, we increase the sample size. And that's exactly what happens with the true calculated statistical significance, is that when you increase the sample size, you get statistical significance. The second factor is the effect size, meaning how large is this difference? Or how large is this change? This is a graph showing the effect of the effect size. So this is effect size in relative terms, so 0.75 or 1 or 1.5. So for the same sample size, you can have a power of 30 or so to show statistical significance, all the way up to 90 for the same sample size. And that's why effect size with the same sample size will affect your statistical significance. So now if you go back to the example, and I'll give you a different scenario. Let's say when you looked back at last year's numbers, you found that surgeon A did 41, so again, similar, 5 complications. So that's different. So the complication rate of surgeon A was 12%. Surgeon B was the same, so 2.9%. And I'm going to ask you the same question. Do you feel confident that surgeon A has more complications than surgeon B? Probably most of us would still say, not really, but boy, I'm concerned. Although the sample size is the same. And you're probably not going to need to go all the way to 20 years. You're probably going to stop here. You know, looking at 5 years, 13% versus 2.6%, you're probably going to have enough confidence, which will translate into statistical significance, that this difference is real. And that's the effect of the effect size. And in this case, the effect size is a difference in proportions. Okay, so how do you use this knowledge to better plan our research? So we said 2 determinants of statistical significance, sample size and effect size. And if you think about these 2, the effect size is the function of the intervention itself. You have nothing to do with it. You know, whether drug A versus placebo reduce blood pressure and how much is the reduction, you have no control on that. But you can control the sample size. So that's why we do what we call sample size calculation to better plan our research. There are 2 major advantages of doing sample size calculation. One, it gives us more confidence about the statistical significance. I showed you for the same intervention, you can get statistical significance by just increasing the sample size. But if you calculate the sample size before you collect data and then you find it, it is less likely to be due to chance. So it gives us more confidence that this is truly a true finding, a true difference. The second important point is that it helps minimize the risk of unnecessary recruitment and or performing unfeasible studies. Sometimes you're just not going to have the statistical power to show the difference, or you might not need as many events as you think. So just to give example for the first point, so it gives us more confidence. Again, this is difference in mean. This could be heart rate, blood pressure, whatever you're studying. And you can see for the exact same numbers, you can get a p-value of close to 1 all the way to 0.00001 by just increasing the sample size. So what you could do for the same intervention, you keep collecting until you get this. I'm not saying people do that, but in theory, that could happen. But if you had decided your sample size before collecting data, and then you find a significant p-value, then our confidence that this finding is true is more. The second thing, it helps minimize this noise in the literature about underpowered studies. This is a very interesting study. You'll see here it was published in 1962, but it's really cited a lot when you read about this topic. What Dr. Cohen did in this study, he looked at 80 studies and then assumed a medium size effect, then calculated the power in each one of these 80 studies. And what he found is that 50 or 60% of the studies published were underpowered to show medium-size effect. Meaning, the fact that these studies reported the non-significant p-value was predominantly due to a small sample size. And had they calculated the sample size, they would either change the outcome, not do the study, or not add to the confusion of the literature by reporting underpowered studies. I'll give you a personal example where a sample size calculation was really, really helpful. I only do this because I know all the details, so I think it fits, it shows the benefit of doing sample size calculation. So this is a study where we looked at continuous QT interval monitoring versus standard of care in COVID-19 patients. So you'll remember early on in the COVID-19 pandemic, we used multiple drugs that prolonged the QT interval. For the non-clinician, the audience, QT interval is an electrical parameter that if it's prolonged, it increases the risk of malignant arrhythmias and death. And the standard way of monitoring that is by doing electrocardiograms every day. There's new technology where you can continuously monitor the QT. And if it's prolonged, this system will alert you. So the hypothesis was that because we're using new drugs, multiple drugs, if we use this new technology, that will detect more QT intervals. Now, the conventional, if you like, way of doing these studies is that you come up with the idea, you say, okay, this is a good idea, let's start. And then you start collecting data. And then someone asks, well, how many patients do we need? And you say, well, just start and we'll see how it goes. Or maybe a senior member of the research team will say, I think we should collect 100 patients because it makes sense to collect 100 patients. But a better way of doing this is you actually do a sample size calculation, so which we did here. So before collecting data, we calculated the sample size we need. So you'll remember that we said determinants of statistical significance are sample size and effect size. So if you're calculating sample size, you really only need to estimate the effect size, which in this case, difference in proportion. So you need to read the literature and see what do you expect to find when it comes to prolonged QT using the continuous QT technology versus the standard of care. And we thought 30% and 10% is the number reasonable. And when you do the calculation, look at the number we got, 62 monitoring days. These are not patients' days. If you assume, an average stay of 5 days, this is only 12 patients. It's really nothing. I think it took us 2 or 3 weeks to collect data. I don't think without doing the sample size calculation, you wouldn't stop at this small number. So this goes back to why we do it, because it helps minimize, the number of patients, which translates into less cost, less, time and effort and so on. What did we find? So we found that actually we detected prolonged QT 35% using the continuous QT monitoring technology versus 11%, which is very similar to what we estimated. And that goes back to the first benefit, which it should give us more confidence that this is it's less likely to be due to chance. We didn't collect data and then said, let's calculate the p-value, and if it was positive, we'll stop. We predicted that it will be 30%, and we got 35%. We predicted that it's going to be 10% in the center of care. We got 11%. So I think it gives us more confidence that this finding is true. All right. So next is, so we talked about how to plan research, how to interpret statistical significance. And I'll give you an example. Let's say you're reading a randomized clinical trial that compared drug X to placebo in patients post-myocardial infarction. They reported the following cardiovascular mortality rates at 1 year: 10% in the drug arm and 17% in the control arm. And the p-value, this is a true p-value, by the way, the p-value was 0.372. So my question to you is, what would be your conclusion? Is it A, drug X is not effective in reducing cardiovascular mortality? Or is it B, there is no evidence that drug X reduces cardiovascular mortality? Or is it C, placebo is non-inferior to drug X in reducing cardiovascular mortality? I'll give you 30 seconds to think about this. Okay, so the correct answer is that the correct interpretation of this is that there is no evidence that drug X reduces cardiovascular mortality. A common answer would have been A, that drug X is not effective in reducing cardiovascular mortality. And you see this in some abstracts. And we'll talk about why this is not necessarily the right answer. But let's say you read the paper, and I'll give you a piece of information that I didn't give you first time. You find out that they actually only included 50 patients in each arm. Now, I hope if you chose A, you'll know why A is not necessarily the right answer. Because the fact that the p-value was not significant using the conventional 0.05, not because drug A is not effective. It's just, this is underpowered. In fact, there was less cardiovascular mortality. You just didn't have enough patients in the study. And this is only one reason why you could find a non-significant p-value. There are other reasons, related to the conduct of the study, crossover, loss to follow-up, and so on. So the fact that you find a non-significant p-value does not mean that the intervention is not effective. It just simply means that in this study, you did not find evidence that it does reduce the mortality or whatever outcome you're after. And then you will have to decide if that's because the drug is not effective or because of many other reasons. All right. Last question in the statistical significance theme, which is how is it different from clinical significance? So if you remember the example, we said at the end that we're statistically speaking, think that surgeon A has a higher complication rate than surgeon B. Now the question is that clinically significant? And that's a question to you. If I ask you, is this difference a clinically significant difference or not? And the answer to this is you wouldn't know, because I didn't tell you what complications you were talking about. If we're talking about death, then sure, this is an important clinically important difference. If we're talking about an asymptomatic drop in hemoglobin, then 2.5% difference is not really important. And the point is that clinical significance is completely different than statistical significance, and it needs experts to decide. It's not, part of it is the effect size, the number, but the major part of it is a clinical judgment of, is that really important or not? And I think we're fairly good when there is statistical significance in looking at clinical significance separately. We're taught to calculate number needed to treat and absolute risk reduction and those things. I think we're not as good when studies are of small size, so observational studies typically, when there isn't statistical significance. This is scenario B. This is when we looked back, we found that there's a big difference, even from 1 year. Now, you should also ask yourself, is this clinically significant or not? This is a separate issue than statistical significance. Yes, it could be due to chance, so we don't know if it's true or not, but you should be concerned if we're talking about mortality. And when it comes to practically applying this concept, when you report a study with small sample size, it's better to report effect size so people can think about clinical significance. And I would say at the extremes of sample size, when you're accessing data sets with very large sample size, or when you're studying, let's say a rare disease, or you have small sample size, think about effect size and clinical significance and report them. You can report that as in a relative risk or odds ratio, and there are a long list of how you report effect size. But it's really important to report them always, but mainly at the extremes of sample size, because we tend to focus on statistical significance and not really think about clinical significance. All right, so moving on to adjusted analysis. And the first question is, why do we need to do adjusted analysis? Dr. Agnebel did a great talk a few weeks ago about basics of epidemiology, and she touched on confounding, but I'll explain it again. I think it's an extremely important concept, and then we'll talk about statistical analysis that helps with that. So the reason we do need to adjust our analysis is this concept of confounding, which is when you have factors that are associated with an exposure, at the same time associated with an outcome. So if you're looking at, individuals who drink alcohol are more likely to smoke. Smoking is associated with lung cancer. So if you're studying the association between alcohol use and lung cancer, you'll find that people who drink alcohol more likely to have lung cancer. So you would think that alcohol is associated with lung cancer, but in fact, this relationship is actually confounded by smoking. So you don't know if alcohol independent of smoking is associated with lung cancer. I'll give you a real life example. Digoxin is a drug clinicians use in heart failure and atrial fibrillation. There's a lot in the literature about the association between digoxin and mortality. Digoxin can cause some arrhythmia, which can lead to death. So people are worried that it might lead to death. But at the same time, we tend to use digoxin in sicker patients. So this is an example. This is a recent study. I'll explain the figure, and then I'm going to ask you to think about the conclusion from this figure. So this figure, looking at time here is death-free survival. Red is patients not on digoxin. Blue is patients on digoxin. So my question to you is, what is your conclusion from this figure? I'll give you 30 seconds to think about that. Okay, so if your conclusion was that digoxin is associated with death, so that would be wrong because it's confounded, and I'll show you that in a second. The proper interpretation of this is that patients on digoxin are more likely to die than those who are not on digoxin. And the reason is that if you look at the characteristics of patients on digoxin, they're older, they're more likely to have chronic kidney disease, they're more likely to have low blood pressure, and these factors by themselves are associated with death. So if you go back to the figure, this is digoxin and this is mortality, but this association is confounded by these factors. So yes, more patients on digoxin die, but not necessarily because of digoxin. We don't know if this is because of digoxin or because of these factors. This is very recent. This was on Twitter. Some of you might know there was this recent study published in the European Heart Failure Journal, linked aspirin to heart failure, which is a very interesting finding. It was an observational study. And the authors of this study concluded that we need randomized clinical trial to confirm results. And I like how Dr. Turkia, who is a senior researcher, I think out of Duke, response. I'll read it. So he said, no, referring to the author's statement. We need to first be convinced why the results are not confounded. So I bring this because I think recognizing confounding is easy. I think most of us do recognize confounding. It becomes really challenging when you're assessing the adjustment for confounding, because in the study, they actually did adjust for confounding. But how good is that is really tricky. So that would be the next question is, how do we adjust for confounding? And the best way is to do randomized clinical trials, because when you do that, you have a balanced groups of patients, and you're only testing the intervention. But we can't do a randomized clinical trials every time. So for observational studies, we have two major techniques. One is called propensity score techniques, and the other one is covariate adjustment. And I'll explain these. First few definitions, so covariate adjustment. So covariate is it simply means the variable you're adjusting for. It's just a fancy name of any variable. That could be hypertension or old age or chronic kidney disease. Adjustment in plain English means removing the effect of the variable. So when you say, I adjusted the relationship between digoxin and mortality for old age, it means you removed the effect of old age on that relationship. And the statistical technique we use for covariate adjustment is called regression. And there are many types, but the three main types of regression are linear, logistic, Cox or proportional hazard regression. So linear, if the outcome is continuous variable, logistic, dichotomous, and if it's time to event, then it's Cox or proportional hazards regression. What about propensity score? So first, let's define what's propensity score. So it's a score that depicts the probability of being assigned to the exposure. In other words, it summarizes all covariates into one number. Remember, in the digoxin example, there are many variables that are associated with being prescribed digoxin, at the same time associated with mortality. These are old age, kidney disease, low blood pressure. So propensity score is coming up with a score, one number, that summarizes all of this. So if you have two individuals with the same score, their probability of being given digoxin is the same. Then how do we use this score to adjust? There are different techniques. One is matching. So we can match individuals with the same score. Or we can do a stratification where you stratify the whole cohort into a low score, and then you compare them on or off digoxin, for example, or high and so on. And there is the third one, which is called inverse probability weighting. And the name might sounds complicated, but it's actually a very neat and interesting idea. What you do is you give more or less weight to observations based on the propensity score. So in the digoxin example, let's say you have two individuals, both have high propensity score. So both the probability of being on digoxin is high. Both these individuals die, and you're looking at death as the outcome. So the observation is death. Now, which one is more informative to us? The high propensity score individual who was given digoxin, or the high propensity score who wasn't given? It's the one with high propensity score who wasn't given, because the one with high propensity score who was given digoxin and then died, we don't know if the death is because of the score, high score, or because of digoxin, right? So we give more weight to the high propensity score individual who died than the other one, because it's more informative. But let me give you another example. Let's say you have two individuals with low score. Both were given digoxin, both died. Which one we should give more weight? The one with low propensity score who was given digoxin and then died, we'll give it more weight, because we removed the effect of confounding because the score was low. So this death is more related to digoxin than not, and so on. Now, we don't do the software will do all this complicated math, but the idea is this, is that you give more weight or less depending on the propensity score. There's one combined technique where you do the propensity score and then you use it as a covariate. You know, once you get this number as a score, you say, this is a covariate, really. You deal with it as if it's hypertension or old age, and you add it to the regression model. Now, which method should I use? This is not an easy question to answer, but if you have time, this is really an interesting review paper published in JACC. And they did something very interesting. They accessed 4 or 5 databases. They asked questions, and then they did all these different techniques and compared results. We'll go through this quickly, and then I'll have one slide to summarize main findings. So here's an example. They accessed the database of CHARM trial. This was a randomized clinical trial of candesartan, I think in heart failure. But the question was, is beta blocker use associated with mortality reduction or not? So you see that crude, so no adjustment, is different than adjusted. All these are adjusted, but really it didn't matter much what technique you use, you get similar estimates. Note here that they had lots of events, about 2,000 deaths, and they adjusted for 18 variables. We have this rough rule of 1 to 10, so you can use one variable for 10 events. This is not a must, but it's a rough estimate of, you know, how many variables can you include in your adjustment. So the conclusion here was, you know, if you have good numbers of events and you didn't use too many variables, really the technique didn't matter much. They then looked at another randomized trial, but this time, not too many events, so about 56, and they used 39 variables. And what they found is that stratification didn't give us a good of estimate with a very large confidence interval. So maybe when we don't have too many events, or if you're using too many variables, stratification is not the best technique, but others had similar estimates. And then they accessed a very large observational study data, thin database, looking at statin and mortality. And you see here that they had about 15,000 events. These are deaths, and they adjusted 48 variables. You see how the crude and the adjusted are very different because this is an observational data. You see that techniques did really well, except inverse probability weighting, which didn't do as well because this is observational study, there are few variables that were very strong confounders. The effect was just too big, and this technique didn't do well. Okay, so in summary, what does that really mean? They concluded that there are a few details that you have to pay attention to. So maybe stratification is not good when you don't have enough events. Matching, because you match one-to-one, so you lose a lot of individuals in the study if you don't have the exact match. So maybe it doesn't perform well when the sample size is not big. An inverse probability weighting, when you have very strong confounders, didn't do well. But really, the technique wasn't, otherwise, the techniques didn't differ much. So what they suggested is that you have to pre-specify your technique. And then if there are these unique issues, you deal with them and you choose the proper technique. But then it didn't really matter much what technique you use. So what you shouldn't do is you run the different techniques and then pick the one that fits what you think is the truth. You have to pre-specify. But people spend probably more time thinking about the technique than what they should. All right. Next is, what is residual confounding? And I'll tell you about this very interesting study, again, back to digoxin and mortality to explain residual confounding. I told you that this issue of whether digoxin is associated with mortality has created a lot of confusion, and there are just so many studies looking at this question. So this is a systematic review published in BMJ, where what they did is they looked at all studies that examined the association between digoxin and mortality, and then divided the studies into randomized clinical trials, unadjusted analysis, and adjusted analysis. And this is what they found. They found that there was no association in the randomized clinical trials, the biggest one being the DIG trial. There's a clear association, or a strong association with mortality in the unadjusted analysis. And we explained why that is, because we do prescribe digoxin in sicker patients. What's really interesting, though, is that when they looked at adjusted analysis, it was all the way from very similar to unadjusted analysis to very similar to randomized clinical trials. So my question to you then, why is this variation in the adjusted analysis? Why did people find a wide range of differences, closer to unadjusted all the way to closer to randomized clinical trial? And I hope you don't say the technique used, right? Because we just discussed that technique is important, but it's probably not the major determinant of the results. The reason is this concept of residual confounding, which means confounding that you didn't adjust for. So no matter what technique, you will have to decide what factors I'm going to adjust for. And if you don't include all the important factors, there will be residual confounding, because there are residual factors that you didn't adjust for. And that's what probably makes the difference between studies when it comes to adjusted analysis, how much you lift out. This is just an example of how important residual confounding. This is a neat analysis out of the DIG trial. So DIG randomized patients into DIG versus placebo, and didn't show association with mortality. What they did here, they said, okay, we're going to look at patients before randomization. Some of them were prescribed digoxin by their clinicians, but they're allowed to enter the study where they stop digoxin and then they're randomized to either digoxin or placebo. They showed that if you're prescribed digoxin, your risk of death is higher, which we know from before. But what they did then, they said, okay, we'll see if actually randomization made any difference. Meaning if you're red, i.e. you're prescribed digoxin, a clinician thought that you deserve digoxin, whether you were given digoxin or not, did that actually make any difference in the association with mortality? And they adjusted for about 50 variables. And what they found is actually not. It didn't matter if you're actually given digoxin or not. You just by the fact that you were a clinician thought that you deserved digoxin were associated with mortality. And that's just a good example of how residual confounding, how strong is it in observational studies. So how do we interpret adjusted and plan adjusted analysis? Because there will always be residual confounding in observational studies. So first, interpreting research. And I think the main thing you need to think about is recognizing residual confounding. I did say that I think most of us will recognize confounding, but the tricky part is actually recognizing and assessing residual confounding. Just by chance, I was the other day preparing a talk on atrial fibrillation, and I came across this study, which was published in Circulation, but 2004. I think there was less emphasis on methodology, 20 years ago. And what they showed is association between atrial fibrillation and sleep apnea. And they did do adjusted analysis. But then you read the whole paper, and this is the only description of their adjustment. It says, after adjustment for relevant covariates. What does that mean? How many factors? What are these factors? So when you read an adjusted analysis, you need to ask yourself, what factors were adjusted for? Are these enough? What are missing? How big do I think residual confounding is? Because that will make a huge difference in the interpretation of the study. And then when you plan your research, you need to think about minimizing residual confounding. As I said, there will always be residual confounding because you can't control for everything. But the less residual confounding, the more robust results. And this happens because you think about residual confounding. I'll tell you, for example, in this study, we sat down and we said, what can affect QT interval? Let's make sure we collect them. And that's the power of having prospective studies, because you have the control of what data you collect. But oftentimes we access established data bases, or there are factors that we don't collect, we can't collect. So what do you do with that? And what you need to do is you just acknowledge residual confounding. You have to think about what factors I missed, how big is that? And then you tune down your conclusions when you think there's big residual confounding, and discuss it in limitations. Excellent. So that would be it. I'll just spend the coming 5 minutes answering these 10 questions quickly, just to summarize. So why do we need to test for statistical significance? Because we need some confidence that the difference is not due to chance. Remember, this is not white or black, and this is not proof. This is just a piece of evidence. Sample size and effect size are the major determinants of statistical significance. How do you use it to better plan our research is by doing sample size calculation. It doesn't only produce more robust evidence, but it can help you. It can help you by minimizing the number of patients you need to enroll, and maybe deciding if this is not feasible and you need to change the outcome or think about something else. When the p-value, how to interpret statistical significance, when the p-value is more than 0.05, which is the conventional cutoff, that doesn't mean that there is no difference. It just means that there's no evidence of difference. You will have to decide if that's because the intervention is not effective, or other reasons like, not having the power to show it, or issues with the conduct of the study, and so on and so forth. Very important to make the distinction between clinical significance and statistical significance. Extremely important at the extremes of sample size, when the sample size is small or very large. Report effect size and think about clinical significance. We need to do adjusted analysis because of confounding. And there are two ways in observational studies to deal with it. One is covariate adjustment by doing regression. The other one is using propensity score techniques Which method should I use? It really doesn't matter much. What's really important is that you pre-specify what you're going to do. Again, just so it's not by chance, you don't do multiple techniques and then use what really fits what you think is the truth. But you say, I'm going to do covariate adjustment, and I'm going to do a sensitivity analysis using, matched propensity score or whatever. And there are a few technical aspects of each technique that you might that might affect the choice, but it's really not as important as people think. Residual confounding is really, really important. It means that there are factors that you didn't adjust for. When you interpret any adjusted analysis, you have to ask yourself, how big is residual confounding? There's always residual confounding. And when you plan your research, try to minimize it by including all important confounders. And if you can't, you just have to acknowledge that in limitations. How to interpret and plan, we discussed it. It's really just by thinking about these factors before, if you're doing the research, or when you interpret research, thinking about what they missed and how important is that. Thank you very much, and I'm happy to take any questions.
Thank you very much, Dr. Weil, for excellent talk. Very nice lecture about what many of us perceive as a complicated subject. You went nicely over many examples that highlight the very complicated concepts, at least for many of us. But these are really basics of statistics that we really read every now and then, and daily in articles that we read every now and then. There's a question from the audience: how do you go about sample size calculation?
Yeah, so actually there are many online websites and softwares that are free. The calculations themselves are simple. What's really important is the how precise is your estimate. Meaning, so in the example I gave, if we estimated the proportion in the standard arm, let's say 20%, and in the continuous arm 50%, everything will be wrong. It's not because the calculation itself is wrong, it's our assumption. And actually some funding agencies will not fund your research unless you show by systematic reviews that you came up with the best possible estimate. You either cite a systematic review or do one, because if you get that wrong, everything will be wrong. So to answer the question, the calculations themselves, if you actually Google sample size calculation, for the common statistical tests, it's actually available. What's really hard is coming up with the numbers, these estimates, and it depends on the topic, of course, but on you looking at the literature.
Or maybe even better, to sit down with somebody like you. So basically sit down with a biostatistician or somebody who knows about how to calculate sample size, rather than improvising or try to do something that you're really not expert at. So I really urge people, whenever they try to do some sort of large studies, clinical studies, to really sit down and with somebody who's expert in statistics, biostatistician, somebody with master's or a PhD in clinical epidemiology, and really put the ideas down and really to have a more accurate estimation of the sample size, rather than doing a lot of effort and then really being criticized heavily by the reviewers, or getting really hard time to be accepted in a journal. It's interesting, Dr. Weil, that still till now, just yesterday, I just went across a paper published in the European Heart Journal comparing angioplasty versus CABG. And just because it's a 10-year follow-up study, they basically publish in the European Heart Journal. But once you start reading the article, you wonder how come it made it to that landmark journal. And again, goes back to what you just said, that basically sometimes the journals are very fond of some studies that are really tackling hot topics, controversial topics, particularly when it provides a controversy around the same issue, and it actually adds more controversy rather than trying to settle the issue. And the editorial about that article actually criticized it very heavily, that the numbers are very small after 10 years of follow-up. It's all based on post-hoc analysis. And it really was surprising to have such a trial published in a major journal. Obviously, other factors play a role, like investigators and big shot researchers. Any comments about that?
Yeah, no, it's amazing. You know, once you start looking at the technical details, you'll find even in big journals, high impact journals, that simple stuff are missed. And I'm no one to editorialize, but I think the peer review process, at least in the past, are mainly done by content experts and not necessarily people who are experts in statistics. Nowadays, I think high impact journals will have a separate statistical analysis. The European Heart Journal is one of them. And these things shouldn't be missed. And it's fine to have these limitations, as we discussed in the presentation. There will always be, but you need to discuss them, and you need to tune down your conclusions when you think there's important confounding missed. But as you said, the topic itself, investigators, the time sometimes dictate what gets published and what doesn't get published.
I also like the way that you refer to the p-value and how some people are really don't spend the time and effort analyzing the paper, the other major factors that can actually play a role in the in interpretation of the study, and whether you should actually believe that p-value or not. Any comment about something that has been looked at differently by different researchers, the run-in period? Whenever some randomized trials start investigating some new molecules, the ARNI for heart failure, basically they included a run-in period where they really tried to test with which patients would tolerate the drug, and then they would randomize patients. And they end up with very significant p-values. Some people criticize this methodology that you actually got out the, you downplay the side effect profile of the drug by basically doing such a run-in period. The other opposing team would say, well, this is experimental design. We want to put in the best scenario what would be the result of testing that molecule. Any comment about that run-in period in randomized trials?
Yeah, because estimating events is such an important thing. When you talk about randomized clinical trials, you're talking about millions. So when you do run-in phase, that helps, right? Because you will have more data. You're not accessing old studies, observational studies. You have the exact drug, the exact population. So it does help you better plan. The issue, as you mentioned, is that this is not really, when you generalize the finding, this is not really all comers. There's a selection bias, because you selected people who tolerated, you selected people who didn't lose follow-up, you selected people who didn't have adverse events. So are you going to, at the end of the study, are you going to say this drug works in this population? That wouldn't be accurate, because it wasn't that population. It was a selected group from that population. So that's really the major issue from the run-in phase. But what people do nowadays, there are other techniques that you can help. Instead of calculating sample size, what you can do, you can calculate event rates. So you say, I'm not going to fix that. And you see this in the more recent randomized clinical trials. You say, I'm not going to calculate sample size. I'm going to calculate event rates that I need, because that's really what matters. And, you know, I can't come up with a good enough estimate. So I'm going to continue. I don't know which group they are in, but once I reach an event rate of that number, then the study will be concluded. So people are coming up with novel techniques to overcome this issue of not having, you know, precise estimates. But you have to be careful because everything has, you know, issues, and you know, the run-in phase is just an example of how we're trying to avoid a problem, but we create another one.
Great. Any last thoughts, Wael? Any suggestions for such a virtual research academy? Any advices for the future? Anything that you'd like to see in such a forum you'd love to see?
Well, first of all, actually, I congratulate you and the team on this great initiative. It's really much needed, and I think it creates a culture of better science, because we do have probably, there's a lot of publications, but not a lot of good publications. I don't have particularly anything specific, but I think one way, maybe just a suggestion is approaching people who attend these meetings and ask them what they want to see. Because as you know, there's just unlimited number of things that you can discuss, but if it's tailored to what people need, then it might make it more helpful.
Fair enough. Thank you very much, Wael. This is very valuable. Again, thank you for your time, and thanks a lot for accepting the invitation to speak to us today on a Saturday afternoon. And we're really looking forward to have you again in this forum, and stay safe.
Thank you very much. It was really my pleasure.
Awesome.